Hello, everyone, and welcome to Heads Up, the weekly webcast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, migraine strategist, founder of the Facebook group Migraine Nation, and chronic daily migraine survivor. I am very lucky to be here today with Dr. Larry Charleston IV. Hello, Dr. Charleston. How are you?
Hello, everyone. Thank you, Dr. Weitzel.
Thanks for being here. Dr. Charleston is a clinical associate professor in the Department of Neurology at the University of Michigan. He specializes, publishes papers, does a lot of work in speaking in the topic that we are going to talk about today, which is achieving equity in headache medicine. And it is a very timely topic today. There happens to be a request for information out from the NINDS. If you're not familiar with that, the NINDS is the National Institute for Neurological Diseases and Stroke. And this is something that we get to all participate in, not just researchers and physicians, but anyone. We can answer this in order to help put headache medicine on the map. And so, on the national map even. So it's kind of important. And he's going to talk to us about this today. So why don't you can pull this up on your computers. We're going to go ahead and put the website, it's kind of complicated. We're going to put it across the screen so everyone can see it. But you can also just Google the NINDS request for information on headache disparities. So Dr. Charleston, I want you to go ahead and start talking. You're sort of the expert in this area. So why don't you just start by, can you just define for us what health disparities really are?
Absolutely, my pleasure. And again, thank you for having me here. It's such a pleasure, and I appreciate and honor to have the opportunity. And hopefully we can all together make a difference. So the health disparities are, the CDC say they are a preventable difference in the burden of disease and injury, violence, or opportunities that to achieve optimal health that are experienced by one socially disadvantaged population or by a socially disadvantaged population. The Kaiser, I also like the Kaiser Foundation, Family Foundation's definition. And they talk about a health disparities refers to a higher burden of illness, injury, disability, or mortality experienced by one group relative to another. In contrast to a health care disparity, which typically refers to the difference between groups of health insurance coverage, access to and use of care, and quality of care. So just a little bit of a difference. The health care is more of the access and the health coverage part, whereas the health disparities is actually that higher burden of illness and injury or disability or a mortality experienced by one group relative to another.
Okay. All right. So that is sort of what we're talking about today, is some disparities in healthcare, specifically to headache medicine. Now, can you go ahead and we'll switch to sort of talking about this form. Why is this form so important, this request for information that the NINDS has put out related to headache medicine?
Yes, I think it's really, really important because there are disparities that exist in headache medicine. This form, the background of this form is to try to, for the NINDS, National Institute of Neurological Disorders and Stroke,
yes.
And they do a lot of the funding for neurological disorders. We already know, and my good friend Dr. Shapiro has been a big lead and advocate for getting more funding for headache disorders.
Right.
And so this gives us the opportunity. The more people that respond, gives the opportunity for those stakeholders who make these strategic decisions to say, okay, maybe we need to think more about headache disorders. Okay, we need to think more about headache. And so the purpose, and this is a time-sensitive request, is to seek input from scientists, clinicians, patients, families, caregivers, advocates, the broader community. And so it just makes a really good opportunity because I can't, even though I do care for patients with headache disorders, I mean, I'm not in their shoes, right? And so they can actually tell their story. I would suggest being succinct with it, but tell their stories of where they feel, whether they feel like it's an access problems, whether they feel like it's prior authorizations that a lot of us have to struggle with and try to overcome to get medications, whether they feel like they're not included in different studies, whether it's just a lot of different things. They ask for different areas across the lifespan. So I'm mostly adults, but what about peds? What about pediatric population? A lot of times, sometimes the pediatric populations can't even express exactly what's going on. I know Dr. Hershey and Scott Powers and Dr. O'Brien and Kabush and just that whole group. I mean, I know they've done a lot of work in peds and Dr. Yonker and Dr. Winter and everything, but I'm hoping that we are reaching people who, because the P's probably not going to be able to, the kids not going to be able to do it. It depends on what their age is, right? So adolescents could. They probably can outdo some of the technology than you and I both, right? But like the parents of children that suffer from different headache disorders could actually reach out to and say, hey, we need more studies in P's, or we need whatever they feel like they need. And so that's why this is important.
Yes, and I will definitely, we will be sharing this. People in the pediatric migraine groups will be seeing this. It will be seen in those groups, and the parents can go to fill out the form. That is a big deal to me. I had daily migraine as a child. So many of the podcasts we do on medicines, it is almost a little bit heartbreaking because I always ask the question, can this new medicine, is it indicated for children? And the answer is almost always no. So I think it's really important to, give a shout out to the parents of kids who have headache disorders, who have migraine, who have cluster, that they go and fill out this form and talk about these barriers that their children are experiencing. So is there I think you mentioned that the language of the form is not exactly easy to get through. Is this true? I think there were some things you wanted to go ahead and define for people to make it a little simpler.
And so, so when we look at inequities and what they're asking for, so I'm just trying to get what they're asking for and what they're trying to do, and they have it in their background where they look at identifying and monitoring, targeting biologic, environmental, social, behavioral, healthcare system, social economic status, sex, sexual orientation, gender identity, all these different disparities. So inequities, or areas where there may be inequities, or areas where there may be disparities. I have a particular interest in African-American populations. So that's kind of a little bit of that background. But when we go through the form, even when I go through the form, like, I can try to identify these areas. I get that part. But then, like, this determinants. Okay, so what does that determinants mean? And there's a nice article that actually talks about social determinants, because there can actually be physical determinants. There can be social determinants. Okay, and so just to give you an example, the physical determinants could be like the environment, the green space. Like, so we know in asthma that where there's a lot of pollution, that may trigger some of these attacks. So there may be physical determinants. There may be, work sites. I'm always trying to have patients get things more ergonomic for them. There can be exposures to toxins or physical barriers or anesthetics or different elements or what have you, lighting, the way that things happen, so those are physical determinants. And then there can be probably more common in these disparities are maybe social determinants as well. And so that's the availability of resources to meet daily needs, access to education, the healthcare services, the quality of education, public safety, social support, social and economic conditions, language barriers, literacy. I actually published back in 2016 health headache literacy, which is based off the World Health Organization health literacy, and how literacy is just not simply just knowledge. I mean, cultural, access to mass media and emerging technology. So we get back to the access. There's different devices and things like that, and it requires a smartphone for you to use it, right? If you don't have that, that's a social determinant where there may be a disparity in the outcomes that you can have due to not having a device. But again, the community-based resources, transportation, not having access to get to different things. So I just really wanted to kind of share what these determinants could include. It could be any one of these, doesn't have to be all of these. But could include. When we get to the next question, which is really the third main question that they ask, because they ask some demographic questions: evidence-based research strategies, health services, policies, other interventions. And I mean, unless I think you work in that space or one works in that space, it may be difficult to see. I mean, there are, and I want to say this real quickly, but there are different phases of generations of research when it comes to health disparities.
Right.
And there's an article by Dr. Stephen Thomas and colleagues that talks about toward a fourth generation of disparities research to achieve health equity. And in this article, he talks about there's the first generation is actually the document and existence of health disparities. Well, in our Alaskan natives or American Indian or Native American population, there's just not even a lot in headache medicine. I mean, there's a few in with African Americans, but some of these are small scale studies and some of them are sample based studies. But so that's the first generation. We need to document the existence of this. The second generation explains the reasons for the health disparities. So we're talking about health disparities research, right? So you have a first generation that documents the existence. We need to know what they are. We need to know what these, and they actually ask a question, the gaps of what we know, what we don't know. But it has to be something that we think about, okay? The second generation explains the reasons for those health disparities. And so that may be some of those determinants, right? It may be something with the determinants that cause, it may be something else. It may just be attitudes and beliefs, it may be that I don't believe I need to see a doctor. I don't believe, even though I may be disabled from my headache, I don't believe that, I believe I have a religious belief that I think that this is a punishment or whatever. I don't know what those are. I'm just making these up. I know that there's been evidence in cases of that in epilepsy, right? but to understand the reasons for the health disparity, the third generation is actually providing solutions for eliminating health disparities. And so with headache disparities, that's kind of where we get into some of the interventions and things like that may actually eliminate that. But his fourth generation, he talked about us having our own, understanding our own biases when it even comes to research. What we bring to the table when we have, when we, as researchers and things like that. So when there's evidence-based strategies, this may be something for research strategies. It may be something that is done outside. In most cases, it is things that is done outside of headache medicine, because we're still in that first generation / second generation phase of research.
Yeah.
But there could be policies, right? So there could be some policies that are put in place, maybe that deals with insurance, so people have access to medications, things like that. So the other thing I want to say about the forum is you may not need to, if you don't know things or someone doesn't know things, you may not necessarily need to fill out everything, but fill out what you do know and what could be helpful. I admit, like, some of these things, I mean, I don't know all that. I think mixed methods research, I think community-based research, community-based or community engagement research can kind of help with this, with disparities.
Right.
And so I think that those are different things that have evidence-based, but if you Google mixed methods research and migraine, you get very few, if any, results, right? So it's something that we need to do. And then I talked about some of the knowledge gaps. We just really don't know. And that's like, what don't we know? Sometimes we don't know what we don't know. At least I don't know what I don't know sometimes.
I think that something that people need to understand as they fill out this form is that, we don't understand all of it. We Google stuff as we read it. And one of the main things is that we're trying to get across is, if you're in a group where you're noticing that when medicines come out, either you can't take them because they weren't studied in your population, or you're taking them, but your group was not represented in the clinical trial. This is something to bring up. If you have hemiplegic migraine and so a medicine came out and they say you can't take it with hemiplegic migraine because no one with hemiplegic migraine was in the trials, or if you're in the pediatric population, if you're a kid and it wasn't studied in pediatrics, these are things to bring up. And then what about ethnicity? I mean, are most ethnicities represented in these clinical trials? Is this a problem?
Well, I think it is a challenge. I try to view things as challenges and not problems.
Right.
The challenges you can overcome.
Good point. Good point.
But absolutely, there was a review. It was published in 2017 by Nathaniel Roberts and James Burnett. And they actually I looked at a few studies, in fact, 128 relevant clinical studies. And based on their criteria, only 36 met their inclusion criteria. Mm-hmm. And I was just going to say these numbers here. And you guys, the name of this, I don't like the name. I don't like minority. I don't like the term minority because minority is not empowering. It's based on a social, race is actually based on a social construct as well. But let's say underrepresented representation in migraine treatment trials. Mm-hmm. And so they, 100% of these studies reported gender frequency. Only about not quite 70% reported ethnicity or race, and amongst all studies, women and whites represented 84 to 83% respectively of all the participants. As far as the average of participants, and the studies, in fact, that were in the U.S. that was funded by a private company were more likely to report race than the studies conducted outside of the U.S. Or with a public sponsor. And there was no studies that stratify efficacy or safety by ethnicity or gender. Men and non-whites in the U.S. were statistically underrepresented here. So yes, it absolutely make sense. They concluded that the most recent headache studies that comply with the NIH mandate to include women and they said minorities. Again, we don't like that term in clinical trials. Particularly in the U.S. in industry-funded studies, they did that. They complied with that, but whites were overrepresented compared to both the general population and the population of people with migraine. And right. So they suggested future studies should strive to increase underrepresented ethnicity populations or participation and investigate race-based differences in migraine expression, treatment responses, and medication toxicity. So yes, this is it's a problem. It's a problem I think we've had in the headache community, and I think that we all play a role in this. But we all can play a role in looking to the future and doing better things. I had this thought of the day. I do a lot of different things, but I put this thought of the day said that I refuse to let darkness of the past shut the door on a brighter today and tomorrow. So I think this is something that we all can actually work and strive to do. And
that's a great quote. That's a great thing to say. So basically, what we would like to get across in this episode is some of the disparities that exist in headache medicine, and that there is definitely a way to overcome this challenge right now that's been presented to us. And the deadline is July 15th. Am I correct to fill out this form?
This is July 15th, and we want headache at the table. We want headache medicine at the table. We want the National Institutes of Neurological Disorders and Stroke to take headaches seriously.
Yes, we do.
Yes.
So if you're watching this, go ahead, pull up this form, fill it out to the, with the knowledge that you have and with your experience. And so is there anything else you would like to add to this topic today, Dr. Charleston?
No, so one thing is, back when it was originally, so the deadline was extended from June 15th to July 15th, which was great because it allows more people an opportunity. It started if you're looking at the website, it started back in March 31st, but of course there's a lot of things going on.
Right.
But I also tweeted links to different studies, because maybe you just want to participate and you don't know. But I actually tweeted links to studies that could help. So a lot of them deal with race. I think some of them may have some social economics. Some of them have some prevalence. Because there are studies that you can you can Google and just kind of look and kind of read, and if you just want to add. So, you guys are welcome. It's not a plug for my Twitter, that's fine. but I am I am on Twitter at LCharlestonIVMD. So L Charleston IVMD, and you can actually just to have a list of some of those references, and kind of scroll through. So.
Wonderful. Thank you for that. All right, everyone, that is all we have for today, but I believe we will have Dr. Charleston on again in the future. So thank you, Dr. Charleston.
Appreciate the opportunity.
Thank you, everyone, for joining us today.
Thank you,
and we
everybody.
will see you next week on Heads Up, the weekly webcast and podcast of the National Headache Foundation.